Welcome everyone to today's webinar, which is an update and an overview of the Medicaid transformation demonstration. We appreciate your engagement and your joining the webinar today. And as such, we are planning on a pretty comprehensive overview of this subject, as well as a time for your questions and answers and some dialogue among the panel. So as such, please make sure that you're submitting questions throughout the webinar. You can do so in the text box. And we will be answering questions at the end of our presentation. So today's agenda, we are going to do a little bit of level setting around the demonstration and its timeline. And we're going to take a deeper dive into the project toolkit today and talk about how you can engage and some opportunities for feedback that's coming up. We also want to make sure, we know there's a lot of interest in the demonstration across the state, and so we are going to provide you with some tools today and resources that can help you speak to your own networks and constituents about the demonstration. So today we're going to be hearing from several leaders across the Healthcare Authority. Marianne Lindeblad is our Medicaid Director. Nathan Johnson is our Chief Policy Officer. Mark Province is our Medicaid Transformation Manager. And Kaylee Klein is our Health Policy Project Manager. So a little bit of background on Healthier Washington. Healthier Washington embodies our commitment as a state from Governor Jay Inslee through his cabinet, agencies, and legislative support from across the state and our stakeholders and partners to improve the health of people in Washington state and our communities. Our primary objective is to transform the health system to achieve better health, better care, and lower costs for the people of Washington state. We have multiple implementation mechanisms for Healthier Washington. That includes some foundational legislation that was passed several years ago that includes many elements of Healthier Washington that we will talk about today, as well as others. We did receive nearly 2 years ago a State Innovation Models federal grant that is $65 million over 4 years to implement Healthier Washington. And also the Medicaid transformation demonstration is an implementation mechanism for Healthier Washington that really accelerates the goals of Healthier Washington, its strategies, and really focuses on our Medicaid population with the desire to lift all boats. So no matter what, if we're talking about the demonstration or the grant or legislation, Healthier Washington has 3 simple goals. A Healthier Washington is one where people and communities are healthier. Washington's healthcare system delivers whole person care, addressing the needs of the head and the body in a coordinated way. And the care is affordable. It's those 3 interrelated goals working together that will create the system change that we're looking for in a Healthier Washington. With that, as a basic overview of Healthier Washington, I'm now going to turn it over to Marianne Lindeblad, our Medicaid Director, to give an overview of the Medicaid transformation demonstration. Marianne.
So thank you, Laura, and just a little more context on the demonstration. So this is an agreement with the federal government and will allow us to demonstrate that we can achieve a transformed Medicaid healthcare system that really does improve healthcare, health outcomes, and saves us dollars. This is a 5-year demonstration, and it will provide up to $1.5 billion in federal investments, and really to invest in incentives for delivery system reform, and also provide some critical services and support some critical services for our Apple Health members over the next 5 years. So fairly straightforward, the major transformation goals, of course, to have a more of an efficient delivery system and avoiding the use of intensive services and settings, reduce hospitalization, nursing homes, improve population health, improve the health of the populations we serve, to really move us more quickly to transform from a fee-for-service delivery reimbursement system to value-based payment, and ensure that our per capita cost growth is below national trends. Our transformation goals are all consistent with those of the federal government. I'm sure most of you have heard quite a bit about our various initiatives, but just as a quick reminder, we have 3 initiatives. The first one is about transforming the Medicaid delivery system within each region in our state to care for the whole person and use resources more wisely through our accountable communities of health. The second initiative proposes to expand options for people who are receiving long-term services and supports so they can stay at home and delay or actually avoid the need for more intensive services, and provide support to families that are caring for loved ones while increasing the well-being of the caregivers. And finally, our third initiative is for our most vulnerable populations, provide some targeted supports in both housing, supported housing and supported employment to get and stay healthy. So within 5 years, this is what we expect to see: a system that integrates care for the whole person, tools that support providers in achieving the transition from fee-for-service to value-based payments, and more of our clients engaged in their own health. So next, I'd like to introduce Mark Province, the Medicaid Transformation Demonstration Manager, who will share the near-term timeline for this work.
Thank you, Marianne. We're currently in a pre-implementation phase for the demonstration waiver. As this slide illustrates, we, as you may recall, reached agreement in principle with the federal government in early October, which really confirmed the basis for an agreement, the details of which are currently being worked out in our special terms and conditions. That's the reference to STC negotiations on this slide. So this is essentially where we work out the terms of the agreement. Remember that this is a contract with the federal government. The other significant activity underway is the development of our project toolkit. We shared a draft of this in November, a pre-draft, and are continuing to work on the development of the toolkit, and there will be an opportunity for 30-day public review of the toolkit when we have finished our current drafting. Once the demonstration begins, there is another segment of activity. Actually, you can go back to the timeline. There's another segment of activity in which we develop protocols which create the opportunity for us to work out additional details in terms of the project toolkit and other components of the agreement. So this is ongoing work and work in which we expect to engage our partners in the public quite a bit. So moving to the next slide then, we do tend to use a number of different terms, and just as a reminder, some of the more significant ones in terms of this discussion are STCs, or special terms and conditions, and again, these are the contractual terms of our agreement with the federal government. The protocols really are, as shown here, programmatic and funding details developed once those terms and conditions are final. So this is really, if you will, kind of a two-step process in which we work out the contract terms and then provide additional details in the protocols. The project toolkit itself provides guidance and structure for our accountable communities of health so that they can develop their transformation project applications. There are additional terms that are defined in an online glossary that's accessible through our website. So with that, I'd like to turn the agenda to Kaylee, who will talk a little bit more about the project toolkit.
Thank you, Mark.
So today we did want to focus a little bit on the project toolkit itself, given the high level of interest and upcoming opportunities for public comment on a comprehensive draft project toolkit. So through this demonstration, funding will be available to incentivize providers to pursue activities in support of delivery system reform. The Medicaid Transformation Project Toolkit is really a portfolio of transformative projects that are eligible for incentive payments. The toolkit is and was designed with state and regional health priorities in mind, along with input from cross-sector subject matter expertise and broader stakeholder engagement. The evidence-based guidelines and recommended strategies outlined in the projects are intended to target the significant health needs and gaps in healthcare delivery facing Washington's Medicaid population. So if you look at the graphic here, you'll see that there are 3 domains within the toolkit. Domain 1 focuses on health systems and community capacity building and really are those fundamental activities to be successful in domains 2 and 3. So domain 1 does not outline individual projects, but are really required focus areas to be implemented and expanded across the delivery system, inclusive of all provider types. Domain 2 focuses on care delivery redesign, and Domain 3 is focused on prevention and health promotion. And again, I really try to remember or think of these as a portfolio of projects that are very much interrelated and interdependent. So these projects will also build upon and help to accelerate the foundational delivery system transformation work currently underway in Healthier Washington. And the toolkit itself provides more detailed guidance for project implementation. So as Mark had mentioned, we do have a pre-draft available on our website. That draft is currently being revised, but it gives a pretty good indication of where the toolkit is going. And you'll see for each project area there are target populations, recommended partners for implementation, project rationale and objectives, recommended guidelines for project implementation, and project-specific process milestones and outcome metrics that will tie to incentive payments and ensure accountability. So using the toolkit, each accountable community of health will work with providers in their region, both traditional Medicaid providers and non-traditional providers, to develop a regional project plan. This plan will reflect the set of projects that region is choosing to implement, and that region will demonstrate how those projects are going to address identified gaps in care through innovative strategies in the context of their communities. Another thing I just want to highlight about the project toolkit is there are a few of these projects that are listed as required for each region. They will certainly look different from one region to the next, but bidirectional integration of care and primary care transformation is a required project, as is community-based care coordination. Both of those are in Domain 2. And then in Domain 3, addressing the opioid use public health crisis is a required project. And then the selection of another project within Domain 3 is also required. So in summary of required projects, ACHs will oversee and monitor activities across all Domain 1 focus areas, at least 2 Domain 2 projects, and at least 2 Domain 3 projects. So that's really the project toolkit. And again, as Mark had mentioned, upcoming public review opportunities in the next coming days or week or so. And we are looking at a 30-day public review and comment period for that for the project toolkit. But again, would encourage everybody to at least check out the pre-draft materials that are on our website. So now I will transition over to Nathan to talk a little bit more about what else we can expect moving forward.
Thank you. Thank you, Kaylee. Before I mention some next steps for us, I should acknowledge a frequently asked question at this stage, which is with regard to federal administration turning over, which was a certainty at this stage, regardless of the electoral outcome, what the status of this demonstration is and our negotiations. And I'll say now that we have always planned, even from 2 years ago when this endeavor really began, to complete our negotiating process prior to the federal administration's turning over. There is, in the past, very strong precedent of states like ours achieving very large demonstrations of this nature, even as presidential terms close out. So what we have at this point is absolute confidence that the terms and conditions for this demonstration will be done and will be final prior to the turnover of administrations. And we also have the assurance of the nature of this demonstration, which is what Mary Ann spoke to. This is a two-way binding contract on the state and federal government once it is signed. It cannot be violated by either the state or federal government without cause. And even if the state were to pursue removing itself or extricating itself from the demonstration in the future, it wouldn't be without very significant notice and phase-down requirements. Similar activities would be required of the federal government related to public notice, hearing rights, etc. So we feel in very good stead that at this point we will be talking to you come January about implementation efforts for this demonstration. And again, would remind folks and acknowledge that we have always planned on having the details of this from a terms and conditions perspective worked out before the turnover of administrations occurs. Going on then to some things you can expect in demonstration year one. First, at the top level, we should say, and again, I think this has been consistent from very early on in this process, the first year of this endeavor will really be ramp up. We are in the build-out stages in year one, meaning that whether it's the services that you see in Initiative 2 and 3 or the projects being undertaken under Initiative 1, there will be a significant planning and development phase and early implementation efforts that will be underway across all of those domains of projects that Kaylee referenced as we get further on into year one. So what can you expect then immediately ahead of us? First, we are very much anticipating being able to announce the completion of negotiations on special terms and conditions. So we are very much looking forward to that, as I'm sure CMS is at the same time. You will also see shortly upon the conclusion of these terms and conditions the efforts of accountable communities of health to put together their projects and begin the application process. You will also expect in the first several months following terms and conditions a variety of public forums to discuss details of the demonstration and its implementation. It is our intent to get to all 9 regions of the state represented by accountable communities of health in these public forums and to do so by early March. So we're coming your way very soon. So then how can you prepare for all of that, all of this activity? First, we certainly encourage continued engagement around the accountable community of health tables and as well with local providers. Help each other figure out what this opportunity will look like within your region. While there are certainly some standard elements of this, we recognize that health delivery is local and that health transformation must be driven locally to be sustainable. So we encourage you to engage around those local tables. Another step you can take at this stage is to inform yourself. Review the toolkit once the formal draft is posted. And I should also mention there is presently a pre-draft of the toolkit that's posted for folks who want to get an early start on that before the formal draft is delivered later on this month. You can read through and visit our resource library, which includes both written and virtual materials. And we'd also encourage you to become familiar with the terms we use and the different documents that we offer online, including the glossary of terms that was referenced earlier. The other thing we hope you'll be willing to do, making use of these tools and information garnered from this webinar, is to communicate to your partners, to your employees if that's the case, and to other stakeholders that are in your circles to keep them informed of the activities under this demonstration. So we recognize that you have questions and that you have your own stakeholders beyond just this very webinar to communicate with. And again, we've provided a variety of tools. You'll see some of them listed up there that you can access right now today to further inform them and yourselves. And you can visit our website at hca.wa.gov/HW, which will link you to all of these materials. And I would also encourage folks to continue checking on the website because we will be posting more updated videos very soon, as well as additional written materials as they become available, which includes the project toolkit. The best way to continue to stay informed, and I expect with many of you participating in the webinar today, you've already done this, but please join our Healthier Washington Feedback Network. There are ways to do so online, and we will put the web address on the screen in just a moment. So we're going to now get to your questions and your comments. Laura, if you could help us, what's our first question today?
So as promised, we have a lot of time for questions, and we've received several already around timeline, financing, resources, and the project toolkit itself. For those who have yet to submit their question, please do so in the chat box. Let's start with a specific question about the project toolkit. Some, and one person here on this webinar did say that even just one of these initiatives and projects within the toolkit is a heavy lift. Kaylee, can you speak to how projects build upon and reinforce one another, as well as how many projects we expect each community to take on?
Sure. So in terms of the number of projects each community will take on, I had mentioned those required projects for each region. So supporting the activities within Domain 1, so really focusing on those foundational elements that are necessary to be successful in our Domain 2 and Domain 3 activities. So we're focusing on workforce and financial sustainability, and I'm forgetting the other one, which I should remember. I'll go to my little graphic here. And systems for population health management. So the activities within Domain 1 are expected to further support how care delivery redesign and prevention and health promotion activities will be undertaken. We also really envision that a lot of that work is also going to have to happen at a statewide level, acknowledging that we don't want to build capacity in 9 different regions when really it would be most effective done on a more statewide basis. In terms of the number of projects per region in Domains 2 and 3, there are 4 projects, but again, thinking about it, the decision of the community as to who, meaning which providers, will be participating in those projects. So it's not to say that all providers, however defined, will be engaged in a bidirectional integration of care project, but really a region looking at the activities that are already underway, thinking about how best to build upon those activities in pursuit of the goals for Medicaid transformation, and having those providers come forward who are interested in undertaking the activities listed within the toolkit for each of those project areas. So while the number of projects required is 4 plus the activities within Domain 1, in terms of how many providers are actually participating in those and how it looks from one region to another will really be up to that community to decide through their project plan application, which there will be a lot more information on the application process to come. But again, to the earlier part of the question, we do see this as building on existing efforts, not looking to duplicate, and more importantly, making sure that we are leveraging what's already there within a region. So whether that's looking at how to improve care coordination by building on existing efforts with other with care coordination efforts through health homes or other models that are already there, and really not duplicating services that we are already doing through Medicaid.
Thanks, Kaylee. We've gotten a couple questions about how the projects and the initiatives, the projects in the toolkit and the initiatives of the entire waiver align with health transformation work that's already going on in Washington State. health homes, the SIM grant, and other work. Nathan, do you want to speak to how this work builds upon and aligns with everything?
Sure. The good news for Washington is that we are not starting from scratch when it comes to health transformation. The work of health homes began earlier in this decade. In 2013, the work of innovation planning began in almost a year-long stakeholder-driven process. In 2014, the legislature passed legislation directing much of this work, including the full implementation of integration in Medicaid by 2020. And so we are starting from a good base of both strategic direction as well as transformative activities at the local level. So this demonstration is meant to further fuel and accelerate that work. Whether you're talking about particular project domains under the Toolkit, for instance, Domain 1 here, we're talking about capacity building in service of Domain 2 and 3 activities, but in service as well of broader health transformation objectives for those delivery systems. The other thing that's recognized is that Medicaid does not exist in a vacuum. Medicaid is one payer of many, whether you consider Medicare or other commercial interests that are at the table working with the same health systems. That's one important reason, although we didn't spend much time talking about it today, efforts around value-based payment are meant to closely align with those efforts at a national level, as an example with Medicare, and we have chosen to align ourselves with a federal framework for how to measure value-based payment for that reason. So we see, again, the demonstration and the investment that it comes with it as a vehicle for accelerating the strategic direction, the innovation planning work, and some of the early success stories that the State Innovation Model Grant have provided, but bringing them to scale throughout our state and throughout every region of our state. So I hope that addresses your question. There will be much more to come, but I would say more tactically that the process of project planning, which is a very important phase and much of year one will be focused on, will be an important effort to align ongoing and future activities in the way that the questioners, I think, were asking.
Thanks. We received a question about, or a couple questions about the demonstration as a whole, including some requests for updates on initiatives 2 and 3. Nathan or Marianne, can you speak to the status of those 2 other initiatives?
I can speak to them, sure. The status of Initiative 2 is the elements of that program approach that have been discussed on prior webinars around tailored supports for older adults and alternative benefit, called MAC for short, Medicaid Alternative Care, are fully intact and are moving forward under Initiative 2 of the demonstration. And we have terms and conditions in draft form from CMS to reflect that. Initiative 3 also remains very intact. However, because of continuing conversations at the federal level, we are still waiting to receive draft terms and conditions for Initiative 3. And so as soon as we do, of course, we'll be following the same process we have for Initiative 1 and 2 terms and conditions, which is reviewing them, revising them heavily if necessary, and sending them back to CMS, all, of course, on a very truncated time frame. So, in short, I guess in summary on all 3 initiatives, the programmatic objectives we have been laying out for 2 years are moving forward on all 3 fronts.
Thanks. We also received a question about the budget and the $1.5 billion, or up to $1.5 billion over 5 years. Where does this go, and where does it come from?
Well, that's a good question. I'm going to take that one more. This is Nathan again. First of all, the where does it come from? Maybe we'll start there. The federal investment under this demonstration comes primarily from 2 sources. And for folks not as familiar with Medicaid parlance, the term non-federal share, I'll introduce another term of art to today's discussion. Any Medicaid expenditure must come with non-federal share. There are various ways of producing non-federal share, including general fund dollars from the state budget, including intergovernmental transfers, which are dollars received from other public entities, and a new opportunity that's specifically available under this demonstration but not otherwise available is to designate state health programs as meeting a Medicaid interest and draw in federal match for those programs. So for this demonstration, we're using two of those. We are using just over $900 million of designated state health programs over the 5 years. These are programs today that do not receive federal match, but have a nexus that is to Medicaid populations that they are serving, and for which CMS, under this demonstration and under the agreement in principle we have reached them, have granted their status as designated state health programs. So that is one source. The second is intergovernmental transfers, which under this demonstration will come primarily from public hospital partners. There is precedent in the state and ongoing already intergovernmental transfers that occur to fund certain elements of the Medicaid program. We will be using a little more than $550 million of intergovernmental transfers to draw in federal match associated with this demonstration over the 5 years. Where those dollars go? They go to the three initiatives. They go to incentive payments under Initiative 1 for the delivery system reform activities that are being undertaken. They fund the two types of services under Initiative 2, and they fund the services under Initiative 3, supportive housing and supportive employment. So I hope that is a high enough level response, but give you some detail on where the money comes from and where it is going. And we're happy to address any follow-ups on that if helpful.
And looking out 5 years and beyond, how are we measuring and what are our expectations around financial sustainability? Nathan.
I'll go ahead and lead this off and then invite others around the table. This is a great question and something that we have been building into the frame of Medicaid transformation from fairly early on. The last thing the state wants to do, and I assure you the last thing the federal government wants to do, is stand up new projects or new services that are not sustainable the moment the demonstration goes away. That would do an incredible disservice to the people who we're trying to serve through this demonstration and to the providers and other community partners participating in it. So for that reason, we haven't just proposed project undertakings under Initiative 1 or services alone, as they are under Initiative 2 and 3, but we have proposed an actual transition of the business model for Medicaid from one that rewards volume and widgets of services and care that are provided at the provider level to one that instead pays for value and pays for outcomes. And with this new flexibility and this new business model arrangement, we are convinced that transformative care models, like integrated care models developed and implemented across every region, models of regional care coordination, approaches to addressing opioid abuse will be sustainable under a new business model and sustainable without the specific federal funding that's available for the next 5 years. If you can think of it this way, the federal government's really willing to partner with us by providing some venture capital, but they expect us to be able to sustain it once the 5-year demonstration is over through the return on investment that's being garnered through these particular initiatives. So we are working closely with our managed care plan and provider partners to ensure this reality, but sustainability will also be a key component of each project submitted, as well as a key component of our evaluation efforts to ensure over the life of the demonstration that efforts are being undertaken in the most sustainable way possible.
Thanks, Nathan. So we've received a lot of related questions about roles in Initiative 1, particularly around accountable communities of health, providers, and payers, and how these relationships will work and what kind of roles each sector will take on in implementation of Initiative 1. Mark, I'm hoping first you can provide a high-level overview of the role of the accountable communities of health and the interplay with those that sit around the accountable community of health table, including providers, payers, and others.
Thanks, Laura. Well, you actually anticipated my answer, which is one way in which we're assuring a meaningful role of each of these parties is in the construct of the ACHs, remembering that the ACHs actually began to form under our SIM grant, and we've been able to, fortunately, take advantage of their effectiveness as community collaborators and collectives to ensure that there is meaningful participation between the ACHs and their constituent members, which include, as Laura mentioned, providers and managed care organizations. It's important to remember that ACHs are not the same as managed care organizations. The MCOs remain responsible to the state under contract to deliver Medicaid-covered services. That also serves as a reminder, by the way, under the waiver that this waiver does not alter the benefits currently received by Medicaid beneficiaries, but really, as Nathan mentioned, is a way to really move forward in terms of transforming the ways in which we deliver care and services so that by the end of the 5 years we actually have a transformed and sustainable system. So I would say that the providers in each ACH community bring their unique perspective in terms of their relationships with patients and participants in delivery systems. The MCOs bring their expertise to the table in their role as financiers and coordinators of care. The ACHs bring the expertise as conveners within their communities. And then there are, of course, additional members around the ACH table representing those who are involved with social determinants of health, community organizations, beneficiaries, others who contribute really to a collective picture of how we can improve the delivery of care and the improvement of health to beneficiaries within each ACH community. So it's really a model that we think makes a lot of sense, and that obviously, having reached agreement in principle, our partners at CMS recognize as well.
Thanks, Mark.
If I might just add, Laura, one thing that folks may not appreciate from a more federal perspective is some of the distinctives of this approach. And I think another thing that attracted CMS to this demonstration, we are in fact under a demonstration required to demonstrate something. One of it is what Mark covered with the multi-sector approach. The second piece, though, that's I think a very important distinctive is the level of payer engagement or managed care organization engagement specifically in the actual design, development, and implementation of the transformation projects. In other states that have implemented similar waivers, that level of payer engagement has not been as prominent, especially on the front end of the process. Here in this state, managed care organizations are involved in governance and leadership capacity in every accountable community of health. And that is a clear distinctive, and we think a clear indicator of future success of this work and sustainability. And finally, it's not just a multi-sector approach that takes in other stakeholder feedback in terms of building out the projects, but it has a balanced decision-making component, meaning there is no single provider group or provider type that is a dominant or the sole dominant force within each of these ACHs. So whether it's the multi-sector approach around decision-making, whether it's the payer involvement from the very beginning, or the fact that this is required to have some balance with no dominant force, those are some really key distinctives of the Washington Medicaid transformation demo that you won't necessarily see in other states undertaking similar work.
Building on that thread a bit more, what role will the accountable communities of health play in the selection of projects, and how will those align with their regional priorities? Are there going to be specific criteria that will be applied to the selection of projects? Kaylee, do you want to take that on first?
Sure. The first, in terms of criteria for selection of projects, the toolkit mentions that through the project plan applications, ACHs should demonstrate how the projects that they are choosing to implement for their within their region is meeting a community need as indicated by their regional health needs inventory. So there is an expectation that those projects are meeting the needs, particularly focusing on the Medicaid population and focusing on where there may be gaps to really leverage this demonstration to help with the systems transformation envisioned under this demonstration. what was the first part of the question?
I think you kind of got to it for the most part. Did you mention criteria?
Yes, the criteria, and then the other piece is how this aligns with some of the accountable community health priorities already identified. I think in the feedback we've heard so far on the pre-draft of the toolkit is that it seems that many of our partners and stakeholders are pleased with the projects that are within that toolkit already, and we have heard that it does align with a lot of what the regions were already interested in or already thinking about. So this really is that opportunity to build on what regions have been thinking about for a while. The other thing I would just add is this toolkit has been really developing for the last year, beginning with a project idea solicitation process that many of you on this webinar probably participated in, where we had received over 180 different project ideas, and this toolkit has gone through quite the evolution since last December. Really started by a lot of that activity, which showed a lot of interest in things like care coordination and integration of care and chronic disease management. So a lot of what's in the toolkit was really because that's what we heard from the regions, that is where there was a need.
Thanks. Turning to providers and their role in the demonstration, what kind of clinical practice transformation support can providers expect in assisting with their role? Mark, I'm wondering if you want to kick us off.
Sure. First of all, just as one reminder, under the SIM grant, there is assistance that is made available to providers through our Practice Transformation Support Hub. But I also turn people's attention back to the components of Domain 1, which have to do with capacity building. Again, this is not capacity building for its own sake, but in service to the other projects that are represented in Domains 2 and 3. So the approach here is one in which there's a recognition that providers within an ACH community may vary in terms of their ability to take on certain components of these projects, but that through the support that's available under Domain 1, the providers in that community can develop the capabilities necessary in the earliest period of the demonstration to be ready to undertake those projects, such as bidirectional integration of care. And so as represented in Domain 1, that support can take the form of, or can focus in areas such as financial sustainability through value-based payment, workforce development and capacity, and the systems necessary for population health management. Again, we expect that more of the details in terms of the needs represented by each community will come forward as part of the project application process. But fundamentally, there is a recognition in the demonstration that there may be some capacity building that's necessary.
Thanks, Mark. We have received some questions about incentives and how this is going to work and what kind of incentives there may be for providers, as well as if there are additional incentives available for integrating multiple projects under the toolkit. Nathan, I'm wondering if you want to take that one on.
Sure. I'm kind of do some guesswork at the question and help steer me if folks respond there, Laura. So the way incentives work under Initiative 1 is first there is up to $1.125 billion in incentives. The federal government's pledged over the course of the demonstration for those activities as they are defined in the project toolkit. An important an important distinction between this and what other folks may be familiar with in the venue of health and human services is these are not grants. These are incentive payments, meaning that particular milestones must be achieved in the implementation of projects for them to be paid out. The logistics of that may look a little different based on the nature of the project, but we are planning for quarterly or semi-annual incentive payments on the basis of particular milestones being achieved. And the course will be set for purposes of how those incentives are earned in the submission of the project plan application that Kaylee referred to earlier. So participating providers will be identified, the level of potential incentive payment, if those milestones are met, will be identified, and once the milestones have been achieved or particular outcome measures have been achieved, there will be an assessment at a regional level and a statement that those milestones have been achieved, and an independent assessor operating on both the state and CMS's behalf will attest to whether those key and critical milestones or progress measures have actually been achieved. Then the further logistical frame for this is while projects will be formed and monitored and implemented at a local level, disbursement of incentive funds will be centralized. This is a unique approach that Washington is taking so that we don't have to have the level of significant financial management capacity created in every region to do so. So there will be a central financial executor dispersing incentive payments to participating providers once particular milestones or measures have been met. And for a better sense of what it means or might look like to meet a particular milestone or progress metric, I would encourage folks to look at the draft toolkit that's posted and also keep their eye out for the more final draft version that will be circulated in just a few days. So I hope in that guesswork I got to the core of the question, but if there's follow-up to that, we'd be happy to address it.
Marianne, I'm hoping you can start us off with this next question, which really is how much of this will really benefit Medicaid enrollees and Medicaid beneficiaries, and how much we're also looking to not just touch specific individuals, but also populations and make a difference in the health system for the entire community.
Oh gosh, no, there's quite a bit embedded in that question, isn't there? So what you think about certainly these various projects and the things that Kaylee laid out from the standpoint of what these may take on, you see both the individual and from a population perspective. So if you think about individuals with a substance abuse disorder and how we put together an opioid plan, certainly those are approaches on an individual client-by-client basis, and how do we better serve those individuals. And while it's not so much about paying for the service, in fact it's not about paying for the service, it's about building up the infrastructure so that we have systems that can in fact address a whole variety of issues, care coordination, bidirectional care, again, the opioid crisis, other things that communities might choose. So you think about it at both for a single Medicaid enrollee, but you think about the kinds of efforts that will be developed in a community and how to address certain aspects of a population. And those things are not going to just affect the Medicaid population, but really they will build systemic infrastructure in that community to address the whole population that resides in those communities. So it does, while it is a Medicaid transformation, that transformation, we believe, will carry through to other populations in those communities through our accountable communities of health. Those organizations aren't there just to serve Medicaid, but they're there to serve everyone who lives in those communities as they need something. So when I think about things from a population perspective, the variety of projects that we've selected each have the opportunity or the basis of affecting more than just a single individual, but really serving and changing up how services are delivered, how we build provider capacity in terms of value-based payment, how we build provider capacity in terms of managing populations that have certain chronic conditions. So all that will more fully benefit the population.
Thanks, Marianne. Nathan, where can we look to other states for examples of success? And where, you already mentioned where Washington State is different. Where are we also looking to build upon the successes of other states?
That's a great question. First I'll start with the old adage that you've seen one Medicaid program, you've seen one, and Marianne can certainly attest to that, being a part of the National Association of Medicaid Directors, and there are a lot of eyes on us because in some ways we are trying to do this in a very different way than how it's been done previously. And again, I think that's in part why CMS is interested in working with us in this way. That said, we've learned a great deal from watching other states and their approach to Medicaid transformation work. I would call out in particular New York, which began their Medicaid transformation effort about 5 years earlier than we did with their, and they just announced actually a renewal of the demonstration that they have been on now for the last several years. We've learned a great deal from them on things to replicate, and then they've even encouraged us to do things slightly differently, where they've learned lessons through the hard work that they've been engaged in. I think what they've done very well in New York is they have engaged the provider community especially well through their performing provider systems. They were really starting from scratch. They didn't have anything like an accountable community of health structure set up before their demonstration, so they've had to learn a lot of this along the way. The other thing they've done a very good job doing is supporting the administrative needs of both local communities and the state in putting this work forward. So we've certainly drawn from that success for them. And then in terms of the implementation of projects, a few of us on the team had the opportunity to actually go see those in person. And it is very impressive what can happen with the right level of community and provider leadership and the right level of sector involvement in pulling together key care transformation initiatives that they have undertaken, and in New York's case with a particular priority of reducing inpatient hospital stays, both admissions as well as length of stay. So a lot remains to be seen, obviously, in these other state undertakings because they're only halfway there in New York's case. And from a design standpoint, I'll just call out one other state. We've taken a very close look at California, which has, all of these states have similar priorities to our own. They want to better integrate care, they want to convert to value-based payment, and they want to better engage their communities in doing so. So a lot of common priorities, some different tactics, a great deal of lessons learned, and I think the exciting thing for states in the next several years is we're all going to be learning a lot from each other in both the things we're doing differently and the things we're doing similarly. So I would say more to come on that front as a general answer to the question.
Thanks. We've received a lot of questions about what individual sectors or organizations can do to get ready for the launch of this in 2017. What is the highest impact action that organizations within communities in the more traditional healthcare sectors, as well as those in housing, nutrition, transportation, can take to prepare for Initiative 1, as well as the demonstration overall? Mark, do you want to kick us off?
Certainly. If the question is what's the one thing that those organizations can do, I would have to say it's engage with your accountable community of health. Many of you listening already have, and it speaks well to the success that ACHs have seen so far in terms of the degree of engagement that they've gotten from their constituent communities. But we speak a lot about ACHs in their role, but it's important to remember that the ACH is really represented by its collection of participants. It's not, these are unique organizations, as Nathan pointed out. There are a number of states, I think, looking to our example to see how successful these collaboratives can be. So I would say engagement with the ACH, participation in their discussions, in their meetings, interaction with representatives around the ACH table. Those are I think, some of the key initial activities that I would recommend. The other thing, going back to our earlier slide about what can people do, would be to inform yourself about what's in the pre-draft project toolkit, for example. Our waiver application and other materials are available on our website. It's a lot of reading, I realize, but I think one of the things that people will see is a very consistent set of themes that thread their way throughout these documents, and those all really go back to our Healthier Washington goals and to the national AAA. So if one remembers to think in terms of how to achieve better health, better care, and better control of our resources, you'll find that these documents all fit very well within that frame. But just to put a cap on things, I would say engage with your ACH.
Can I just add one piece
Sure.
to that? And when you think about engaging with the ACH, for those of you that are already engaged with your ACH, look around the table and identify who's not there, and and reach out to them, because there are still participants that aren't there or don't really understand the importance of this work, and so you have a real opportunity to educate and reach out to other community providers, other community assets, and engage their participation.
Thank you, and with that, we are going to conclude today's webinar. Thank you to those who actively engaged with your questions and participation. The slides and recording of this webinar will be available on our website. Also, I do encourage you, as this slide indicates, to check out the website for those resource documents we've been talking about throughout the webinar, other Healthier Washington information. And please do, if you've yet to do so, sign up for the Healthier Washington Feedback Network by emailing us at the email address, the email address on the screen, or visiting the Healthier Washington website. Thanks, everybody.